So let's have a look here. So hopefully you can see the PowerPoint. Can you see that? Yeah, great. Great. So hello, everybody. Welcome to this Lunch and Learn. Yeah, I'm Kristian Hudson, implementation specialist from the Yorkshire Humber. Applied Research Collaboration, also part of the Improvement Academy, which is kind of our implementation arm of that arc. So today, I'm going to talk about implementing for impact, garnering a more realistic approach to implementation research in healthcare. And so I'm going to talk about implementation research, talk about implementation science, and talk about the research to practice gap and some of the main causes of that. And then steps forward. So I'll be talking about implementation research essentials, relational implementation, system change, and then I'd love to have a bit of time for discussion and connect with you all a bit. So I think we might be doing implementation science research that's a little bit unrealistic. So I'll explain this a bit further throughout, but most of the time our research doesn't really lead to or isn't truly able to tell us how to adopt, implement, scale up or sustain interventions. And most of the time implementation still fails, whether it's in a health system or a school system or out in the community. And this might sound quite strange when you're talking about implementation research and implementation science. The question is why? And I ask this because I'm tasked with supporting ARC themes and projects with implementation science. And, what are the ARC values and goals? And it is to learn about implementation, but it's also to have impact and impact patient care and outcomes. And so it's very important that the work we do and the way that I support themes and projects with research, that it's having this effect. And this is what we aim for, and what I've been thinking about for quite a few years now. So just to sort of set the scene, what does implementation science offer? Let's have a look. So there's lots of different definitions. This is a recent one, and I think it's quite relevant to what we're talking about today. So this is saying it's the study of methods to promote the adoption and integration of evidence-based practices, interventions, and policies into routine healthcare and public health settings to improve the impact on population health. So it's quite clearly saying it's about promoting that initial adoption, getting people to actually decide to take things up, getting those things into practice, and then getting those good outcomes and having that impact. So let's look at what it offers to achieve this. I'm doing a very quick whistle-stop tour, but it's just to give you an idea for those that aren't perhaps so familiar. I mean, the main thing that the science has offered, one of the main things anyway, over the last 20 years, it's quite a new science, and the sort of research we've been doing has been theories, models, and frameworks. So this is quite a well-known paper from Nielsen, 2015, and they cut down the sort of frameworks that there are, and there's three main types. So there's the sort of theories, models, and frameworks that describe or guide the process of translating research into practice. There's the ones that talk about what just influences implementation and determinant frameworks, classic theories. And then there's things that kind of help us evaluate implementation. And there's 170 plus of these now. So a lot of effort and work's gone into generating these kind of theories, models, and frameworks. The other main thing the science has done is looked at implementation strategies, and we have lists of implementation strategies, and people have been trying to test them out. It's training, audit, and feedback sort of thing, organizational changes, seeing if they can apply these strategies to context to get specific outcomes. And often the outcomes that we've focused on has been these kind of more academic, generalizable implementation outcomes, Proctor's outcomes you might have heard of, fidelity, reach, feasibility, sustainment, things like that. And in a way, maybe some have been looking for the kind of magic, what's the strategy that will always work, So that's the kind of thing it's been doing. And just to give you a little taste, this is a process framework, the quality implementation framework. Like a lot of the frameworks, it draws from lots of other frameworks, other theories. And this is really just saying, look, if you want to plan your implementation, you want to think about it now, that it might be useful to see it in 4 phases. And it's very logical. It's very rational. It's saying, let's do a needs and resources assessment, a fit assessment, capacity readiness assessment. Let's look at adaptation, get buy-in, so it's just very sort of step by step and can be quite useful for some people. And phase 2, then you make your implementation team, develop a plan. Then phase 3 is when you're actually going to start coaching, supervision, training, technical assistance, etc. The other frameworks, these are ones that we use quite a lot. This is the consolidated framework for implementation research. It's 2.0, so it's a new updated version. And this is a determinant. So framework. So it's very useful for analyzing contexts and saying what is it that's helping or hindering implementation. These are great for all actually telling us what went wrong with implementation as well. Also great for creating strategies. If you can understand, diagnose a context and create a strategy. And there's 5 main domains. So they're saying, look, things about the innovation itself, the thing you're trying to implement, that'll affect implementation. So what's its evidence base? Does it have an advantage for what's already in place? Can you adapt it? Can you trial it? How complex is it? These sort of things. In a setting, what are the relational connections like between people? Informal, formal communications, like say between nurses and doctors. Is there a tension for something to to change about the problem this is addressing? So these inner setting factors, outer setting, financing, policies, external pressure, the individuals, they have the motivation, the opportunity. So it's using a bit of COM-B in there, this behavioral framework. And finally, the process, is there a plan? Are people being engaged? Are they actually doing implementation? So really useful frameworks, these sorts of things. So, and just to give you an example, you can make strategies from this. So, I mean, this is a 2018, Leotel did a 2018 systematic review looking at, I think they looked at 40 different sites, where 40 different studies where a health-based innovation had been implemented. And they applied the CIFA to see what seemed to matter most, and they found it was these things. So leadership was key, leadership engagement, the sort of sustained ongoing engagement of leadership. And this has been found repeatedly to be a huge facilitator of implementation. And in this case, leadership affected these other constructs that also impact success, like networks and communication. So was there communication, collaboration, teamwork, champions? Are they evaluating and monitoring implementation, the culture and resources? So, when you do these kind of analysis using the science, these kind of implementation research, it's useful to understand the context that you're studying. And from that, you could make a strategy. And this has been the thinking. This is Eric's list of implementation strategies, not exhaustive at all. There's 73 in this. It's very well used a lot. It's very well known. There's lots more, but people might look at this list after doing a context analysis with CIFA or another framework, and choose a strategy or design a strategy. And so in this case we might say, well, leadership's really important. We're going to build a coalition. We're going to create and cultivate relationships. Instead of with partners, we're going to focus on leaders. So you might do that. And then there's even logic models. I mean, this one is actually very useful at the end of studies, I think, this model, but you might use it to sort of work out how this might work. So we know leadership engagement matters. We might apply this strategy, and the mechanisms might be something like improve leaders' knowledge and self-efficacy in response to the evidence-based practice, reduce barriers, raise acceptability, increase engagement, etc. And then you've got your implementation outcomes, and that might be that it's implemented and sustained. Your service outcomes, well, in the service, there's more service referrals for this intervention, and clinical patient outcomes, there are less patients left unsupported, something like that. So this is the kind of thing we can do, and it looks great and it makes a lot of sense, and it's been useful up to a point. But let's have a bit of reflection, because as I said at the beginning, I think we might need to be a little bit more realistic about the kind of research we're doing, and reflect really on is it having the impact that we want? Are our ARCs having the impact that we want? So if you're going to do any kind of implementation research, it's very useful to have an overarching strategy and rationale that's couched in a wider theory or framework. So there's loads of things like normalization process theory, the TDF. There's even any of Trish Greenhouse's work, like the NAS framework, where you're taking complexity out of the system. These frameworks are really great, and they can help you think about where to start. Think about how you're going to view the implementation. How you're going to collect data, how you're going to analyze the data, how you're going to evaluate. Are you going to create strategy? So all really useful stuff. But back to that definition at the start, has the science helped us achieve adoption, sustainment, and impact? Well, it's definitely helped us define and categorize common language around implementation science. It's helped us raise awareness. I've had Laura Damstrode on. I've got an implementation podcast, and she's been very articulate in explaining that's what the CIFA did. It brought this the Consolidated Framework for Implementation Research that I showed you, bringing that language for everyone to sort of use around it. It's been great at identifying barriers and facilitators. So there's lots of studies out there that have looked at implementation, might be across multiple contexts, and they've really seen what has been the barriers, what have been the facilitators. They've also been, it's been great that the work we've done is great at creating strategies. But what about actual getting adoption, integration, and impact? Well, I don't think we've actually really achieved that. So, and you might think, why? This is implementation research. So why is it not leading to that? Because isn't that what we're trying to achieve? Well, it's a good question. It's something I've thought about a lot. As I say, I'm trying to help the ARCs with the implementation, help research it. But we've perhaps not been getting quite what we always need. So why is that? Well, I'm going to go through three main causes. There's probably lots of causes, but these are the three that I think are pretty key. Firstly, implementation research isn't connecting to practice as well as we would like it to. It hasn't traditionally done that. So this is a rudimentary diagram of a healthcare system. And as you can see, there are all these different stakeholders within it: managers, facilitators, practitioners, practice leaders, policy leaders, public, patients. And the way that we've sort of been doing a lot of our research, not all of it, but quite a lot of it, and more traditionally especially, we've been on the outside kind of feeding in. We've seen ourselves as objective and separate to this system, and we've been feeding in our findings. So we might, keenly approach these people and say, we've got a really good intervention. We've built up evidence for this. We've shown it works. You should use this intervention. You should implement this, and that's kind of what it's been like. So it's kind of been quite one way, these academic institutions feeding into practice. But you're starting to see quite a lot of reflexivity on behalf of implementation scientists and papers like this. So this Allison's paper, is implementation research out of step with implementation practice? This is really questioning that. And I think what we can say is that relying on traditional research designs, measures, and approaches has restricted the science and the sort of research we've done to academic researchers. So the result of that is that we've really excelled at understanding the problem of implementation. Like I say, we know that it's an issue. We label it. We know what all the barriers often are. We can watch it fail and say why. But we're less good at engaging with how to actually make transformational change happen. We haven't really learned that so well yet. There still isn't really a blueprint on how to do implementation well. And a lot of the empirical findings that we've been generating and publishing in the journals haven't really got into practice. And a lot of the research questions and designs have not been sufficiently informed by practitioners. So the needs of practice haven't been very well met, which is why they're still struggling to implement things. And just an example, 170 frameworks may have actually increased the research to practice gap. Something like the CIFA framework takes a long time to learn. I actually have to work quite hard with research teams. They may be very seasoned researchers, but if they've never used a framework like this before, with 50 different determinants, it's quite hard to code with, and it takes many weeks to learn and get good at. So, imagine a nurse on a ward wants to do some implementation research, or a teacher in a school wants to know how to implement something, and they probably just don't have time to learn a framework like this. So that's just an example. So what do local stakeholders actually need? What's locally significant? These are the sorts of questions I think we need to be asking ourselves more. And this is just to give you an example, the sort of work that's been published. This is very typical. Quite a recent paper, Barriers and Facilitators Influencing the Sustainment of Health Behaviour Interventions in Schools and Childcare Services. You'll see a paper like this for every other intervention there is as well. And they'll identify, 59 barriers, 74 facilitators, multi-level factors, that we need to use strategies to improve sustainment, and we need to do future research to address this gap, and we need administrative support, executive support, staff engagement, support for the intervention, access to relevant and essential resources, etc. So this is the kind of thing. But if you look at this, it's just telling us the problems again. Because the question, how do you get more staff engagement? How do you get more resource? How do you get admin support? At every setting, it'll be a different answer to that question. Somebody in that setting will have to work that out. And that's what we perhaps haven't been very good at understanding. So that's the first cause, really. I think it's this disconnect. Now, the second cause is we've not fully appreciated the complexity of implementation. So this is how, this is a 2006 model of how to get research into practice. And you can see it's saying that you start with your basic research and you need to move through these steps, go through all these steps, and eventually you work with all these different organizations and you'll get healthcare delivery. So it's very causal, linear, it's mechanistic, it's step by step, it's cause and effect. And there's a lot of people still think about implementation in this way. I think when we're working with healthcare systems, we'll put these processes in and this will happen. And, so the reality, it's very different. We're dealing with non-mechanical human systems. We're not building cars. We're trying to deliver healthcare, or we're trying to deliver, work in schools and or out in the community. And so it has serious limitations. What's the reality really like? Well, we're working in highly complex open systems. So implementation science has traditionally been quite a mutt science. It's drawn from psychology, it's drawn from social science, and now it's increasingly drawing from other things like complexity science, which talk a lot about this. And really, you think about any sort of system like a healthcare system, they're made up of multiple stakeholders, thousands of different people with varying levels of interest, capacity, time, all interacting in different ways, all interacting in unpredictable ways. So how these people interact with each other in their context is locally specific. So there's remarkable differences between sites. And so when you think about actually trying to implement things, even if you've analyzed the context in one place and you found that leadership engagement was an issue, the idea that you can apply the same leadership strategy to the next site is not necessarily true. It's probably not going to work because every context is so different. So implementation is not simple, it's not straightforward, and it has to find a place in an intricate pre-existing social environment. So implementing a new practice in the same manner across a health system becomes untenable. So, and just to get this point really across, and I really like this diagram, consider 3 different problems: baking a cake, sending a rocket to the moon, and raising a child. So if you think about baking a cake, the problem is simple, really. We just need to bake a cake. And the definition is quite clear. We know that we don't have a cake and we want a cake. And so if you follow the recipe, which are already set out, you've got the rules, you follow those every time, you'll get a cake. So the success, you just have to follow the recipe. Excuse me. But with a rocket, it's a bit more complicated problem. Maybe we want to fly a rocket into space. Quite complicated. There is some uncertainty around that. We don't know what all the issues will be in building that. But what we can do is get some experts together and we can work and just keep trying to build one and continuously improve the process until we have a kind of a bit like the cake. We have a very complicated, but a recipe to build a rocket. And then you can just follow that then afterwards and you'll keep getting a rocket, right? You just experiment till you get your protocol. But think about raising a child. I'm sure some of you have children, and this is a complex problem. So the problem itself is very much uncertain. I mean, a lot of the time it's uncertain. You don't know from one day to the next what the issue will be. Maybe on Monday they had an eye infection and you had to go to the doctors. Tuesday they were okay and they ate their dinner, and then Wednesday they had the stomach flu, and then they wouldn't eat the dinner that day. And you don't know what the issues will be, but the only way is you just have to get almost stuck in, right? And the rules, that every child's different. So you can't say, well, with my last child, I did this, and so I'll do it with this child. But it's probably not always going to work because it's very different. And so instead of, experts, this is saying we've got to shift to people with deep knowledge of contextual dynamics. So, somebody that spent a long time with their child and has growing up with them will, over time, generate very deep sort of knowledge of them and what they're like, and success really is from continuous adaptation and continuous learning. That's where it really comes from. If you imagine, the old, ships sailing across the Atlantic Ocean hundreds of years ago, the same thing. They didn't know what the problems will be, didn't know what the weather might be like, or what issues or food shortages they might have, and it's continuous adaptation and continuous learning. And so implementation's the same. There isn't this certainty. So we're going to implement this in 20 hospitals. We don't know what's going to happen until we start, right? So this is why it's a complex problem. And so we've got to address it like that. So this is a picture of my son that I sometimes include in this. You don't know what he's going to be like in the mornings. Usually he's desperate to get out of bed. He's talking, he's trying to get out. This morning he's like this. So you just don't know what to expect. So we might need to evolve our research to address this gap and to address complexity. Now, there's one more cause I just want to briefly touch on. There's a clip of this on the YouTube channel. This is Laura Damschroeder, who developed the CIFA frameworks, probably one of the best implementation scientists that I know. And she was saying we might be putting our energy into the wrong places, because what a lot of the work we've done up till now as well as being a bit disconnected from practice and not really dealing with the complexity, it's also focused on the microsystem level. So we put a lot of effort into working with teams on the ground. A lot of the science has been trying to, we're going to train people, change their behavior. We're going to get people to do things differently. We get the patients to do things differently, all microsystem level. But actually, there are these things on the outside, outer setting factors, system factors like financial realities, politics, policies, funding that can literally just kill an implementation effort in a second. So I work on a lot of projects and I see this. You see a great intervention, you see teams that are really keen, and there's a lot of engagement that drives it. And then suddenly the funding's cut or a different government comes in and then it just falls flat on its face, and there's nothing anyone can do about that. So, at best we might find champions to drive something locally, but they're also swimming upstream against the same issue because they can't impact outer setting kiss of death variables either. So we may need to start focusing more on that. How can we actually influence these outer setting things? Maybe researchers, we haven't lobbied policies makers enough. Maybe we're not really understanding that realm enough. So this is a very important point as well. So what should we do? Because I don't want to be like carrying this problem on where I'm just telling you the problems and then saying thank you for coming. I want to try and address what can we do about this. Well, let's look at the disconnect first. Let's look at complexity as well. Now, what I've sort of been thinking about and what I'd like to use are these key implementation research essentials, and I'm still working on this. I may add to this, I may take some of these away, but this is where I'm at right now. So, firstly, move beyond problem analysis. So any sort of implementation research we perhaps might do going forward, we can still do some of the traditional stuff. And I was at a conference a few months back, and there was a panel, debating frameworks, and one member was like, "I'm making a new framework, and frameworks are science, and so I'm never going to stop doing that." And the other two were like, "No, we've got enough frameworks. We need to actually help and do something more practical." I'm on the thought we need to move beyond problem analysis. So let's stop just analyzing the problem of implementation. Let's start looking at actual solutions. And to do that, we need to look at this practical knowledge. So, you might read a manual all about how to ride a bike, but it's not till you actually get on the bike, start riding it, that your brain and the balance centers in your brain and your eyes and everything start to learn how to work together to keep you on the bike. Your muscles will grow, to cycle, and you'll get better and better. And so same with implementation. We need to generate practical knowledge instead of this kind of problem analysis. And so I think research within, not from outside, I'm really kind of saying, firstly, recognize that we are part of the system. We do affect the system. The kind of work we do, the way we do it has an effect. So I don't think we can be truly objective. And, the social sciences, humanistic type work will sort of argue that we're not truly ever separate from what we're studying. And I think it's to acknowledge that and then to actually get stuck in, get involved in these systems and go in and actually be part of them. So acknowledge the value of alternative roles of researchers. So, and we just finished an evaluation of 4 very different programs that were going on and what the program teams had to do. And actually, they're not just there extracting data. They're not just solely trying to achieve program goals like, A, B, and C of, they do loads of other things to actually drive the research. They have to recruit staff. They have to engage sites. They have to embed someone at the site. They have to answer the phone. They have to answer emails. It is a whole load of roles. And I guess what I'm thinking about this is maybe our role isn't just to tell practitioners what to do based on work we've done elsewhere, or isn't just to extract data from them, but it's to truly collaborate with them and maybe actually to influence implementation. Maybe the only way we'll learn how to implement is to try and implement things and actually use research approaches that promote and facilitate implementation. And I will argue that a bit more later. So if you're going to remember that thing about complexity and that you need to be adapting constantly and learning constantly, well, that's the reality. Whenever there's a team implementing something on the ground, for something to not just be implemented, but to be sustained over time, the people involved in the implementation need to be continuously optimizing it in the face of these constant contextual challenges and making it work, because you don't know what's going to come, right? You don't know what problems are going to come each day. And you might need to tweak things and change things and keep it a priority and keep meeting and keep problem solving. And so another science that I draw from and that other scientists draw from is improvement science and improvement practice. You've probably heard of quality improvement and, PDSA cycles and tests of change. So I always try, whenever I'm doing implementation research, is encourage sites to have this process of, ongoing experimentation and learning and creativity, and also put a bit of slack in the system to allow for that. Because, one of the biggest barriers to quality improvement is the fact that any time away from the patient is often frowned upon in the health service. So, we actually use methods. I'll show you maybe later. Lightning reports, for example, 10, 15-minute phone calls or meetings or Zoom calls or go and visit, just to pull them away from their other demands, just to give them time to problem solve the implementation, but also for us to collect data. So we moving on from problem analysis, focus on that practical knowledge, get stuck in, understand your roles could be quite different to just what you might think is traditional research, and encourage second order experimentation and change. Utilize other sciences. I've kind of touched on that. Be reflexive. I think, there's still quite a lot of implementation scientists that aren't perhaps, that they know there's something wrong with the science in the science, perhaps not having the impact we want in reality, but they haven't quite figured out exactly why. But I think there's some have been very reflexive, like Alison Metz, Laura Damschroeder, who was saying, we need to kind of evolve what we're doing. Now, this one, I've kind of bungled a few things in here, but we also need an increasing focus on systemic transformations. I'll touch on this a bit as well before I finish, but, this sort of focus on we're going to change people's behavior to then get what we want. Well, the thing is, if a system's not working, you won't get the outcomes you want. But if a system is working, you won't need to change people's behaviors to get the outcomes you want, because it'll just get the outcomes. So we need to start looking at more broadly and take a step back, almost look at the whole forest, the whole system, and understand. I think human-centered design, actually, people think that's often about dealing with people and designing around people, but actually it's about designing systems. And then the relational aspects of implementation. This is something that's just not been, I think, given enough attention. And actually, just to highlight that, I'm going to focus on that a little bit now. So just look at the relational aspects in a little bit more detail. If you talk to anybody in practice, or a lot of people anyway, who've got experience of implementing something, they'll tell you that actually you need to work with the formal system, so the top-down system of authority that we have in say, the NHS, for example, but also the informal system. So all the relationships within that, and then there'll be influencers and connectors, people that have more influence than others. And there's been this kind of organizational analysis done where they say like 3% often of social influences actually affect 85% of conversations. And if formal leaders don't engage in dialogue with the informal system, you often get failure. So you'll see time and time again, you'll often see a trust or the NHS say, hey, we need to do this. So exec gives something the green light, gives it the funding, gets everybody on board, and it's passed down the chain, but it doesn't quite get implemented. And I think often it's because there hasn't been this engagement of the informal system. There hasn't been those conversations, that engagement, relationship building, and it hasn't become a social kind of movement in itself. So if you really want to implement well, I mean, a lot of people say you start at the bottom of the organization with a group of passionate people who are engaged and alert. And we did that with safety huddles at the Improvement Academy. Started in one ward, working with a very receptive and engaged team, introduced the idea of safety huddles, and fall rates started to drop, and then it spread, and now it's in hundreds of wards. And that was an organic process from the bottom. So having a shared purpose will amazingly have an impact on implementation. Look at COVID. We implemented things in 3 weeks that would have taken 3 months or even a few days. So, and trust and connection, it's so overlooked, and it's seen as something that's soft and that we can't really measure that well. But that is a key part of implementation. It's relational, it's long-term, right? So, and you can see, just very briefly, like formal structure. I mean, this is a kind of a bit American model here, but you see the vice president at the top, and he's got connection to 3 people below him, and then they've got connection to the people below them. And Cole, only person who's going to talk to Cole about this intervention is Bell. But if you're working with informal, Cole knows everybody. Cole's a super connector. Cole has influence on a lot of people. If you get Cole on board, then you're much more likely to influence all these other people and to actually get this thing implemented. So a more realistic approach to implementation research might be to learn how to better engage more with the informal system and ensure learning and conversations across boundaries. So, and this is the kind of papers we're seeing building trusting relationships to support implementation. This is where Alison Metz came up with a theoretical model for this, and they showed it did kind of work. And there are these underlying theories around trust, relational cohesion theory, relationships that emerge from positive affective experiences are valuable, contribute to trusting relationships, as well as resilience, commitment. And to understand others' perspectives can lead to this kind of mutual interdependence and positive effect. And so the outcomes of that, you've got, you can increase stakeholder sense of capability. You can build intrinsic motivation. You can support communication, coordination, collaboration. People can be more resilient. I mean, these are huge, boosters for any implementation effort. But often what we do, we just try and implement things at rocket speed. We put processes in place to try and get them implemented, mechanisms in place, but we're ignoring and we're not really spending enough time engaging. It's amazing how many studies I've been involved in where I've gone to speak to the sites about the implementation and they don't even know what the intervention is because nobody's spoken them to about it. It's just been given the green light and then they haven't really been asked about it. So trust, very important. So I'll just ask a question. I mean, you don't need to answer now, but just to think, what do you value? What do we value as researchers, practitioners, as patients, as an executive at the top? Everybody in the system, a lot of people are quite burnt out. We've all got different demands on us. We've all got different pressures on us. But what is it that might sort of tie us together? And I think values is a good thing to focus on. Finding out each other's values is a great way to build trust. I'm in different meetings, throughout each of my weeks and from all different levels. And I find the more senior up I go in these meetings, the less I know the other people. They tend to be more kind of stressful meetings where I don't know what anyone's values are in those meetings, but they're all there might be implementation leads or, and I find that really strange that we might be implementation leads, but we don't really know each other. This is something Alison Metz does is there are techniques you can use to build trust with people you're doing implementation research with or people you're trying to help implement. So variety in teams is great. You want different opinions and different people from different backgrounds. It can bring a strength to the team, but you need something to kind of align everyone. And I think that's values. So for me, a key value is I want to make a difference in health systems. And I like the people I work with to have the same value because then we're kind of on the same wavelength. And this has been useful with this implementation work I do because, if it's not having impact, we need to do something about it, right? And because it's a key value for me. I can't just keep doing the same research if it's not getting the effect we want. So I think that's how you might deal with the disconnect with practice and complexity is to use these implementation essentials and to use engagement and start bringing people together. But also for the kiss of death variables that just can come along and wipe it out without really anyone having control. These are really difficult to address, but I think it's similar in a sense that nobody actually in the system has total control of these things. Executives are often overlooked, but they're in a very difficult position. Just like practitioners, they're split between financial demands and bottom line demands and the needs of the staff and the needs of patients, and it's very difficult to be in any of these positions. But none of us really have total control of the system, and you see. There are huge problems in the world, like climate change, some people might argue, and like obesity or poverty, and implementation is a big one too. But to solve these, we're never going to solve it if we all remain disconnected across these systems. We've got to work together if we want to have a chance of changing things. And we might need to change the systems, I think. If we're not getting the outcomes we want, it's because it's not working. So it does take kind of brave people to do that. So all these people, I would say, ideally, we need to be working together and maybe like using research approaches like community of practice and co-production, like true collaboration. Look, I've gone on quite a while. I just want to very quickly finish with just some show you some of these ideas in practice. I could do another hour on this, but I'm just going to quickly show you something. So in Bradford, where the Bradford Royal Infirmary and Improvement Academy is based there, we've got, Michael McHugh's one of our co-implementation leads. He's director of Improvement Academy, and he's noticing that a lot of people were coming into hospital with high blood pressure, and some people having strokes. But who were just in the age bracket that was too young really for this. These people are just too young. This is very rare for this age group. Why are we getting so many? And they thought, well, there must be people out in the community that have a high blood pressure and don't know it. And they did a bit of work and they realized that. But then when they spoke to these people, they couldn't get an appointment with the GP. So we're getting a negative outcome. People with blood pressure problems and even strokes. And I think the system's not really working that well to provide that, right? For probably very good reasons, but that is the situation. So what did the Improvement Academy do? Well, this chap here, Shahid Islam, is a community connector. So he knows a lot of people in the community. So he started to go out and connect with them. And we had, this is Zanira Khurshid. She's a research fellow I work very closely with. And she was part of this. And we had one of our leadership fellows who was a doctor who was working with us, and lots of other people. So really what we decided to do, and what the team here decided to do, was we're going to try and do something different. And instead of spending the time, they could have gone out and spoken to people in the community and just analyzed the problem, right, and then published it in a journal. They didn't bother doing that. They just went out and tried to measure people's blood pressure out in the community, right? So back to that engagement piece, that building trust, building connection, sharing values. That was a huge part of this work. The time was given for that. Most studies that we see today, most implementation work, doesn't give time for engagement. It's said, right, we're going to do this. Let's go. Let's start, right? But actually, and you've got to engage people. You've got to bring them on board. Remember that. Target those super connectors. So you can see all the different stakeholders involved here, even religious leaders, community centres, youth groups, local councillors, ward officers. So everybody's getting together. This has become, a social thing. Oh, we all want to do something about this, right? We care about this. And so what was the result? Well, the first day they did it, and they're still doing it today, 103 people turn up, and 90% of them were between 30, 69, 61% had abnormal blood pressure, and 2 of them had to go straight to hospital. So in a way, they've kind of, replaced the system with something else that's very effective. So it's just a good example of how, you might bring some of these ideas in to do implementation. Now, you might say, well, this is implementation. This isn't necessarily the research. Yeah, but we did research of this, right? And I'll just quick show you. This is how I like to do process evaluations. Not all the time, but sometimes. And so we've got this. You've got your evidence-based practice idea or concept, and often, we would implement this over time, and at the end, we would look at outcomes. Say after 3 years, we'd publish the outcomes, and we'd say what the barriers were. We'd say what the facilitators were. We'd say what the outcomes were. We'd say it was or wasn't implemented here, and these were the reasons why, and it was done with fidelity or not, and was it acceptable? But this doesn't tell anyone how to implement it in the future. It doesn't really tell any future sites how to practically implement it. And it doesn't really pick up the complexity. So what we like to do is say, well, okay, we're going to see this as an ongoing process of learning throughout. And we're going to allow that slack in the system to generate that learning. We're going to give them time to problem solve. And we're going to try and capture complexity. Now, this is the 5 circles model. Now, I built this from a 4 circles model that Gabet and LeMay, who were implementation leads at a different ARCA, they came up with. And what I love about this, it's so simple. And this is another way we can connect research with practice, is that we need simple tools for people to use. So what these big 4 circles are saying is that most of the frameworks are saying the same thing, that if you want to understand the implementation, well, what's going to affect it is the intervention itself, the context you're implementing in, the people involved in the implementation, and the methods they're using to implement. And because it's complex, these things are interacting constantly in all different ways. Maybe the context shifts suddenly and changes, and then that affects the participants. And then that you might need to adapt your intervention. Maybe you need to change your method, or if you use a different method, that'll affect your part. So they're all interacting. And the point is that sounds like oh man, that's really difficult. That's complex. But there's so much juicy practical knowledge you can capture during this process by kind of studying what's going on between these things. So I call that within system learning. And so, and of course, you don't want to just look at that a few times. You need to be collecting data quite regularly throughout the process of implementation. And so we use an approach that's rapid. Now, I've seen at some conferences recently people saying, "Oh, we implementation research shouldn't be quick and dirty and rapid. It should be take its time and be long." But they misunderstood the point. Rapid doesn't mean quick and dirty. It just means very robust, but also timely. Because what does practice need? It needs things implemented. It needs answers. It needs guidance now. So we know in the first week how it's going. We don't wait 3 years or a year. We know how the implementation is going in the first week, in the second week, in the third week, or whatever timescales work for the practice, we'll do. This is more relevant data we're now generating because we're picking up what's going well, what isn't going well, any key insights, and it's also quite responsive to their needs. And so I won't go into this much more, but we'll collect and summarize this within system learning. We'll feed it back to them. We'll feed that back into the implementation effort, and then that'll generate more within system learning. So, our roles as researchers, we're not just extracting data, we're building relationships because we're talking to these people regularly.
Kristian, I think you've just muted yourself. Or no, actually somebody else muted you. Doesn't matter. Literally only last slide it happened.
Apologies, it might have been me because there was some background noise and I muted the other people and I might have ticked on Kristian by accident. Sorry, Kristian. We still can't hear you, Kristian.
No, sorry, Kristian.
Is it because I've done it?
I don't know, because I tried to unmute and it's not letting me unmute anybody either. So
I don't know why I was muted. You're right. I'm back.
Yeah, sorry. It was literally last slide anyway.
Yeah, I mean, it was just the point with that slide is that we're changing our role. We're not just evaluating and kind of extracting data. We're facilitating them to do implementation using kind of approaches where we're feeding back how they're doing and supporting that. And that generates more within system learning. So that sort of 5 circles model, is a useful tool for anyone to use. And we also use lightning reports, which, very simple, easy tool to use to evaluate implementation. So I can give that to a junior doctor tomorrow. I don't need to teach them a complicated framework like CIFA. So there you go.
Lovely. Thank you. Love hearing all about that. It makes sense to me. Whilst let's just say welcome any discussion points and chat, but just I want to say for somebody who does that, and I guess does the same for you in a different arc, it's brilliant because actually we know that the implementation frameworks are a science of themselves and are a growing science of themselves. But do they actually help us create this weird magical thing called impact that actually, I mean, we had a session on Monday about impact literacy. None of us actually really know how to do it. And increasingly, as part of NIHR infrastructure, we're having to do it. And actually, we, the ARCs, the NIHR are all starting to talk about knowledge mobilisation now, rather than implementation research or implementation science. So it's interesting to see how the field changes, but actually how you can still be evidence informed and scientifically informed in then trying to work out how do you move something to practice. So
yeah. And I mean, just to comment on actually the knowledge mobilization that they're suggesting we focus on. I mean, again, what is that, and what will those people do? And if we don't get the system to work, it won't matter really. You know what I mean? We can do stuff at the microsystem level, and we can try and mobilize knowledge at that level, and we can do research at that level. But unless we get the system as a whole to work better, it won't make much difference. So I actually think, unfortunately, we're still focusing on the wrong things. We need to de-implement more. We've got to take the complexity out of these systems. I had some doctors on the podcast talking about the amount of paperwork they have to do, and actually, it's done in the with the framing of like this is to make things safer, but actually it's the wrong way to think about it because it just creates more complexity. So you get more chance of something going wrong because there's so much clogging up the system, but also the patient care goes down. There isn't time to spend with patients, so they're not getting the care they actually want. So yeah, that's my that's my view.
Yeah. So I don't want to hog all the times. I can talk to Kristian whenever I want. We have regular meetings. Questions, comments, points for discussion for Kristian. Lots of people said, can they have your slides? Is that okay?
Yeah, I think so. Yeah, we're sort of, you happily can watch the video, but we're not always sharing them just because we might be doing a kind of more of a lengthier version, a training course or something like that. So I'm not sure if I'll have to check with the ARC.
Yeah, or if not, let's just say that, the recording will be online and people can do it that way. It's probably easier, isn't it, that way?
And I know, I do, if anybody wants to just email, they can do. I'm happy to talk to anyone. I like I said before, I like working with PhD students because they're, you've got something you can focus on the whole time that's yours. And it's a great place to do really good implementation research, but also anybody else wants any help, feel free.
Thank you. So whilst nobody's asking, I'll ask some question. We talk about, in our ARC, lots of other ARCs, we talk about co-production and partnerships and stakeholders. And, there's lots of frameworks to tell us how to do it as well. My hunch is that in itself is problematic, isn't it? Or is it,
Yeah, I mean, there's different levels of collaboration, isn't there? And I think a lot of us thought we were collaborating, but still we were really just extracting data still. And I think, that community health checks thing was I think it's one of the best examples I've got anyway from the Improvement Academy, where I think there was some really true collaboration, because we're giving those people in the community quite a lot of power over how the work's done and where it's done and when. So I think that's probably the first pitfall, is to really think, am I actually doing co-production, or am I still just kind of getting people in? I've actually, I don't know I've actually got a slide which I didn't show, really just very quickly, might as well, just so you can see the different types of collaboration. This is spectrum of engagement that I came across, and you can see, the different levels. So often we just ignore the patient, don't we? We might inform them, we might bring them in just to tell them about what we're doing and get their inputs, or we might actually, these higher levels, you're giving them more of a voice, more power, and eventually it gets up to this level. And this won't always be necessary, and they won't always be ready for this, but just so there are different levels. But what sort of issues were you thinking of, Emma? Because let me close this.
I think it's everybody has different spectrums of engagement and spectrums of co-production. I think you can never capture everybody, and so it's actually, how do you're going to go for the ones that talk loudest, the ones you can find. The people that you can't find, the people that don't get involved, are always going to be so very different to something else that you're doing. So I think that in itself, so we talk about co-production, we talk about stakeholder engagement, doesn't necessarily mean to say that's system-wide, because we can't physically do it that way.
Yeah.
So yeah, it's just one of those, I think, as much as the science talks about it, how we practically do it is very different as well. I think, can I pick your brain on behalf of our PhD students that are online? Yeah. So my background is an implementation specialist, and I moved away from kind of the academic side of it to the operational side of it. It's really tricky, or my hunch is that, how can you be an academic implementation scientist but also still deliver both academically and to practice? Is it possible, or does something have to give? Is it life in general that gives?
That's a good one. I mean, look, I would just say, what matters to you most, what energizes you the most. I know that you may have demands academically and practically. I'm kind of lucky. I really want to make a difference at the practice level. I really care about I'm not saying people in academia don't care about, doctors and nurses, but I've seen thousands of them leaving the service. I see the service struggling. And I think that if you think about that rudimentary diagram I showed with the system with all the different stakeholders, they're all struggling. You know, everybody is. And I think that there's a role for us as researchers to bring them together and support them in different ways. Actually help them figure out how we're going to fix things and empower them. I think giving them more power over what happens and how it happens is important. But sorry, to answer your question, I guess I think it just depends on your context and your job. I mean, I do is I tend to work with a lot of program teams which will have researchers and practitioners, and I'll help them design the implementation aspect, and then they'll sort of do the main brunt of paper writing, and I'll help them, but I'll get on that, you know. So I focus a lot on practice, but I get help with the papers. But
yeah.
So
we've got a question from Louise that says, what are your top tips for meaningfully engaging busy clinical teams? So getting what you need to design the implementation in the quickest, most effective way, and lots of long repeated meetings that people then don't show up to.
Yeah, so obviously, like, your engagement's in key, and you know, if they've got a staff room, just go and sit in it for a day, and that when they come in to make coffee, you can just be kind of like, oh hey, who are you? And you, oh, I'm here to do this, and just, you know, actually giving it the time to engage them in different ways. But that's probably one of them. Or get into the multidisciplinary team meeting, or find somebody in that team that's really interested in what you're doing. But just give it a lot of time, you know, and give them time, and they'll appreciate that. A lot of people working in the healthcare system love to have time to actually talk about how it's going. The other thing is use research methods and approaches that aren't gonna, you know, take loads of time. So maybe and that you want things to be as unburdensome as possible. One of the hardest things is getting quantitative data out of these systems, and nobody really has time to input stuff into a computer. Or so often maybe you want it to be automated. If there's something already automated, maybe you can use that. And like I say, we really like to use lightning reports. So we've got, say, for example, some GPs we work with, very, very busy people. It's like, oh, hey, is it okay? Can I ring you, let's say, once every 2 weeks? Does that work for you? Yeah, that's okay. And can I just call you? Yeah, that's better. Just call me, put it in my calendar, or call me. 10 minutes? Yeah, that's fine. So every 2 weeks, 10-minute phone call. And I just say, how's it going? What's not going so well? Any key insights? And then speak to 10 other people or 10 other GPs. And then I give them all the report, 1 page, 2 page night. So they're seeing what they're telling us. So yeah, just good engagement. Use relational, you know, your relational skills that you'll have, and choose approaches that with practice in mind. Don't just do what I just need to get this data. Like, think about what they need.
Yeah, lovely. I do quite often say to our teams, and I've said it to quite a lot of people in the training programs we've done so far, is the whole focus on implementation for impact isn't rocket science. It's just about people and talking to people and being human.
Yes.
But you know, lots of academics have made a whole career out of making it not that simple.
Yes. And you know, I can say we need to see the system will have to change eventually. I think, as a lot of people think it's not working anymore, but the only way that will be is for these different stakeholders to come together. So I'd like to see executives and funders in the same room as managers, clinicians, researchers, and patients, all working it out together. That would be a good situation.
It would be perfect, wouldn't it? Sadly, I don't think it's going to happen. Right, yes.
Well, that's because, you know, Emma, you're somebody this is your question about co-production. If you want to know how to do it well, go and try.
Yeah.
That's ultimately what it comes down to. We can write papers on it and books on it and theories and models, but only by trying again and again and again and again, like Shahid Islam, that guy I showed you, that you'll actually learn how to do it.
Yeah. We also say, as a closing thought, the worst possible thing you can do is not do anything at all.
I think that's right. Yes.
Lovely. Thank you so much for your time today. We all really appreciate it. There's some lovely comments thanking you in the chat. Yeah, and we will share the recording with you, with everybody else. And yeah, thank you so much for your time and your expertise.
You're welcome, Emma. Thanks for having me. I love to talk about it. So thank you.
Great. Right. Thanks, Kristian. Bye.